So, good evening students. Now one of the most important topics that you have to discuss when it comes to microbiology is mucormycosis. So before I start the class, you have to understand the reason why we talk about mucormycosis more so now is because of the incidence which has increased post-COVID. So we're going to cover completely about all of these aspects. What exactly is mucormycosis, which group of agents cause it, what exactly is the features that you see in pathology, in microbiology, and how do you correlate it with radiological findings, what is the treatment modalities that we have. All of this will be covered because this is what is considered to be a clinical Thursday. Now when we are talking about mucormycosis, one of the most important things that you have to understand is how quickly do you identify a case. Now very important to know that whenever you get a case of mucormycosis, the most important thing that you have to remember is for the fact that you are supposed to diagnose the case very quickly, because the mortality is also dependent on how quickly you start the treatment. Now coming to mucormycosis. We have a question here. So this is pretty much what happens in mucormycosis, and if you can see, this is a previously asked question, and when you see a question like this, one of the most important things that you have to see is not just the fact that you are supposed to see it as in the case that you are supposed to identify. Now here is a case where there is a post-COVID patient that they have mentioned with a history of diabetes. Very important to know that this is something that is attributed to uncontrolled diabetes and also diabetic ketoacidosis. A post-COVID patient, again another risk factor that was found to be something that is associated with mucormycosis. Presence with what is considered to be a black eschar, orbital swelling and proptosis, all of this very consistent with what is known as mucormycosis. Now what is the most probable diagnosis is what is asked here. Now to rule out all the others, obviously Pseudomonas infection does not always present with something which is considered to cause orbital swelling or proptosis, but it does cause endophthalmitis and various other conditions. Now acanthamoeba mostly is something that they always relate with contact lens wearers. So that history is very significant when they talk about acanthamoeba. Now of the two, mucormycosis is the dreaded one, and if you can see, the history of diabetes will always be mentioned when we are talking about cases of mucormycosis. Now what is our learning objective? So what are we going to learn today? Now first and foremost, we are going to talk about what exactly causes it. So what is the introduction? It's going to be about what group it belongs to and what exactly you should remember about it. Now the second one that we are going to talk about is what is known as zygomycosis and what are the agents which cause it. So we are going to discuss about all the agents which cause this particular condition. Now coming to pathogenesis and predisposing factors, there are n number of predisposing factors, many of which are something which is associated with immunocompromised state, and we also talk about diabetes. Now clinical manifestations, this is again a spectrum that you see, a lot of various clinical manifestations. Now the important ones that you have to remember is always associated with immunocompromised state. Now diagnostic approach, very important. So we are going to talk about the pathological finding, the microbiological findings as well as the radiological findings. Now treatment modalities, yes, there are drugs which are available. There's the mainstay of treatment obviously happens to be surgery, and that has to be something which needs to be remembered. That's because the necrotic tissue has to be removed for even better penetration of the antifungals. Now role of COVID, now this is the most important thing that you should know. We tend to see that post-COVID there was a lot of incidents of what was known as a black fungi. So they were talking about a lot of cases of mucormycosis, and this was associated with post-COVID for a lot of reasons. So we are going to cover all of these aspects now and see what exactly is mucormycosis. Now coming to introduction. Mucormycosis, this is caused by filamentous molds and they belong to the order Mucorales. Very important to know. So this is a filamentous fungi which is causing it. Now when it comes to developed countries, so when we are talking about countries which are developed, we always talk about immunocompromised state because of various reasons like malignancies. So in a developed country, the most important thing to remember, or what is attributed to it, is considered to be malignancies and lots of the others. Now, when it comes to developing countries, we always talk about what is known as your diabetes ketoacidosis. So, something that is related to basically, uncontrolled diabetes. So, uncontrolled diabetes and also in immunocompetent people following trauma, both of these have to be remembered when it comes to developing countries. Now, mucormycosis, one of the main reasons why it is so dreaded and why we are definitely very scared of when we tend to see it in a slide, is for the fact that this is found to invade blood vessels. It can lead to thrombosis, necrosis and the infarction of tissue, all of which happens very, very rapidly. So, if you do not diagnose it very quickly, there is always a chance that the mortality rises, with each day. Now, coming to the agents. Now, this belongs to the phylum Zygomycota. Now, coming to the order Mucorales. So, what do you have to remember? The most important thing is there are few organisms which you have to remember, which are always associated with it. One such important one to remember is what is called as mucor. You also have Rhizopus, you have to remember Absidia. These are the three important ones when it comes for the exam. And you have to remember there are others also which are grouped under Mucorales which can cause similar kind of symptoms, but for the exam usually they rely totally on Rhizopus, mucor as well as Absidia species. So, order of Mucorales, these are the ones that you have to keep in mind when it is considered to be the organisms or the most common ones which cause mucormycosis. Now, coming to predisposing factors, why do you have to understand predisposing factors? Now, one of the reasons why you should know what are the most important predisposing factors is whenever you encounter a case or whenever there is a history that is given either in questions or when you are practicing, you always should know what exactly could be a underlying factor. So, this gives you a hint as to this could be one of the reasons why this person has ended up with this. So, knowing the predisposing factors is one of the easiest ways to get a differential diagnosis when we are talking about certain conditions. Now, the most important risk factor that we are talking when we are always talking about mucormycosis is diabetes mellitus, uncontrolled, more so with diabetic ketoacidosis. Now, the other ones to remember is your malignancies, be it hematological malignancies or it could also be solid organ related malignancies. Now, transplantation is also a risk factor. Obviously, there is a lot of immunosuppressive drugs which are given which causes a flare up of all your fungal infections. Now, prolonged neutropenia is an important risk factor. Corticosteroid use, now this is something that you need to keep in mind because this was something that was attributed with COVID. So, they had said that there was a lot of use of corticosteroids and that is one of the reasons why they had found that there was an increased number of cases of mucormycosis. Next is trauma. Trauma can also introduce the spores. So, this is one of the important factor to remember, especially in immunocompetent ones. You have what is known as iron overload. Now, one of the things that you have to keep in mind here is iron overload is also something that is attributed to increase in the cases. This could also mean that there is chelating therapy which is given or there is iron infusion given, all of which increases the risk. IV drug users, again there is a risk of the spores being introduced. Malnourishment, especially when we are talking about GI related mucormycosis, malnourishment is another important thing that you have to keep in mind. Now, immunocompetent patients, this is the ones where you talk about the cutaneous mucormycosis most commonly. So, whenever we are talking about immunocompetent patients, we are talking about the ones who are exposed to the spores and many a times it is cutaneous symptoms that we are talking about. So, understand this. The pathogenesis is again dependent on the fact that the spores are ubiquitous. So, these spores are found everywhere. Now, these ubiquitous spores tend to enter the body and sometimes in certain conditions where your cell mediated immunity is compromised, you tend to see that there is an increased chance of getting the infection. So, this is something that you have to keep in mind. Now, coming to the other important thing, what are the clinical types? Now, there are different clinical types that you have to remember. The most important one that you should know is what is known as rhinocerebral mucormycosis. So, this is the most common one. So, if they ask you which is the most common one, this is supposed to be the most common one. So, your ROCM or your rhinocerebral mucormycosis is the one which is most common And like I told you, this is the most common form that is seen in diabetics. So diabetics with ketoacidosis, you are always supposed to think in terms of rhinocerebral mucormycosis. Now coming to the next important one, which is known as pulmonary mucormycosis. Now this is something which happens because of inhalation of spores. So that's the root. So the main effect of it happens because of inhalation of spores. Now the patient is usually immunocompromised, and many a times your malignancies are the ones which tend to give you mucormycosis. So this becomes very important to understand, because whenever you diagnose a case of mucormycosis, it's not just the workup of mucormycosis that you have to do, but you should also think that is there an underlying condition that we are missing out, because this is something that is attributed to certain immunocompromised states. So be it malignancies like leukemia or lymphoma for that matter, or if there is any transplantation done, it kind of becomes an important risk factor to keep in mind. Now the third important one is cutaneous mucormycosis, and like I told you, it's seen in the form of vesicles. You can see it in the form of wound with a necrotic region. Now what happens here is you will be able to see what is known as hairy pus. So it's described as hairy pus because you tend to see in the beginning it looks something like a bacterial infection, but over a period of time you tend to see that the growth on the surface looks more like cotton like. So it kind of gives you what is known as an appearance which is known as hairy pus. Now coming to gastrointestinal. Now gastrointestinal mucormycosis rarely accounts for, it's only about a 7% of the total ones. Now here what happens is it involves the stomach most commonly, and here malnutrition is an important risk factor. So whenever we are talking about malnourishment, this is something that you need to keep in mind. Malnourishment, here we are talking about the fact that gastrointestinal mucormycosis is very commonly attributed to it, and many a times this happens because of ingestion of food and the ones which are contaminated with fungal spores. So it's attributed to that. Now coming to renal mucormycosis, very rare, you don't tend to see it so commonly, but this is responsible for infarction, which is also very fatal because many a times it's difficult to diagnose because it's not so common. So renal mucormycosis, it presents with flank pain, fever and pyuria. So there is pus in urine, many a times with no bacterial organism being isolated, and it turns out to be something which is caused by mucor. Now coming to disseminated mucormycosis. Now what are the important things that you should know? Now whenever we are talking about dissemination, most of the time it involves the lungs, it involves kidneys, it could be GI. So there is always most importantly the lungs being involved. Now the syndrome here many a times can present with pneumonia, you can have stroke, there is hemorrhage and brain abscess which can occur, and all of this can also lead to nerve palsies. So many a times they also present with nerve palsies. You can have abscess which involves the frontal lobe, all of which is very commonly seen when there is dissemination. Like I told you, a compromise in cell mediated immunity is what you have to keep in mind when we are talking about fungal infections, especially mucor. Now coming to clinical criteria. So what are the things that you have to remember? Now clinical criteria, though this is something that is very old, it's still relevant. So this is a clinical criteria that was given by Smith and Krishna, and they had said that there are few things that you have to keep in mind when you're trying to diagnose a case. So now if you would want to diagnose a case, there are certain criteria. Does it fall into this particular criteria? Number one, whenever you have a necrotic turbinate, you can also mistake that to be blood, but make sure it's not blood, but it is nothing but something which is considered to be a black necrotic area. So this is something that you have to keep in mind, especially when you are doing an ENT examination. This is an important criteria that you just cannot miss. Now the next one is the patient complains of blood tinged nasal discharge, and there is facial pain, and everything happens on the same side. So blood stained nasal discharge, and we are talking about what is known as your facial pain. Now periorbital and perinasal swelling with discoloration and induration, one very important warning sign. So whenever there is periorbital edema or there is swelling, always try to rule out mucormycosis. Now next is ptosis. So there could be ptosis, there could be proptosis, and you can also see that there is cranial nerve involvement. Many a times, like I told you, this is something that is attributed or it's considered to be angio-invasive. So there is a lot of symptoms that also occur because of the fact that this is something which is angio-invasive. So this is what is considered to be very important to know. Now this is in fact what was given when there is a person who comes to the emergency. What exactly is considered to be the warning signs? Now first, if a patient complains of sinusitis, a patient is a known case of diabetes mellitus. Two important histories that you have to find out. Now what are the warning signs that you have to know? Now the first one is, did they ever complain of anything like, sinus pain, or did they complain of diplopia or ptosis for that matter, or any swelling? All of this has to be considered as a warning sign. Now you also have your orbital apex syndrome to think about, any ulcer, and if you can try to evaluate and examine a patient, is there any kind of necrotic tissue which is present? So that becomes very, very important, especially in diabetics, and we are talking about rhinocerebral mucormycosis. Now what else can be done? So you have your blood investigations which will be done, which could be basic ESR, CRP which are elevated. You also have your renal tests done. Now renal tests should be done for both the reasons. The first important thing is, do you want to rule out any other renal cause for it, number one. The second one is, many a times the drugs that you give afterwards for treatment in a suspected case of mucormycosis also requires evaluation of your renal parameters, because they are considered to be renally toxic. Cranial and sinus CT scan and MRI, very, very important. One of the most important things that you can do just to rule out osteomyelitis and sinus thrombosis. Now other things that you can do is, you also require an opinion of an ophthalmologist. You would want them to examine, and obviously an ENT surgeon would want to do a endoscopic evaluation. Now the most important thing that you have to do is, whenever you do an endoscopic or a sinus surgery, you are supposed to take biopsies, and the more the better, especially when you are considering the areas which are involved. The necrotic areas, if you tend to see it, you are supposed to collect as much as the material that you can when it comes to identifying the areas. Now the first one, what they normally do is, the moment they collect it, they send it for a KOH mount. So this is nothing but potassium hydroxide which is used, and many a times a simple potassium hydroxide can give you an idea if this is something which is considered to be an aseptate hyphae. So whenever we see an aseptate hyphae in a KOH mount, this in fact rings a bell, and we are always concerned. The second thing is, you also send a biopsy sample for culture. Now culture is gold standard because it helps you to identify the species which is causing it. So many a times you would want to rule out other fungi which is causing it. So when you would want to speciate it, you always require your fungal culture. Now next is histopathology, and obviously there are special stains that they do, like your PA stain, or it could be your Gomorrhe's methenamine silver stain, all of which helps in identifying the fungal elements. Now coming to the inpatient monitoring. So what exactly do you have to do? Clinical assessment, very, very important, because like I told you, the deterioration can happen very quickly. So many a times the patient tends to deteriorate very quickly. Now the next important thing is endoscopic evaluation. You have to make sure that there is CTs and MRIs which are also being taken, and always consider starting your antifungals if there is a high suspicion, and wait for the reports of both the pathologists as well as microbiologists who can give you a clear idea as to how it is. Now many a times these are the ones which grow pretty quickly, so you do not have a delay in the diagnosis, because the culture also tends to come positive pretty quickly. So these do not grow like dermatophytes, do not take about 4 to 6 weeks to grow, and many a times the growth can be seen in about 3 to 5 days. So it does not take too long to diagnose a case of mucormycosis, but having said that, you cannot even lose a day when you are clinically trying to diagnose the condition. So what is the pathological and microbiological features that you should remember? Now first, when it comes to pathological findings, you are supposed to remember that there is giant cell invasion, thrombosis, and you will also see that there is eosinophilic necrosis of the underlying tissue. So this is a typical finding that you see when you take a biopsy. So Gomori's methenamine silver stain is an important stain to remember for all your fungal elements, because it helps to identify your fungal elements very well. So your fungal elements give you a black background, so you will be able to identify the aseptate hyphae very clearly, and that is the reason why GMS stain is very commonly used when you are talking about mucormycosis. Now when it comes to microbiological features that you should know, you tend to see hyphae. So these are usually aseptate hyphae, more or less very broad aseptate hyphae that we talk about, and the branching is considered to be right or acute branching that you tend to see. Two important keywords to remember here. One, for the fact that these are aseptate hyphae, and whenever there is an aseptate hyphae that we see in a KOH mount, it is considered to be something which we have to act very quickly. So aseptate hyphae here, along with branching which is acute, this along with pigmentation helps to differentiate with other fungal infections. So pathological findings as well as your microbiological findings, both of these are considered to be very, very important to remember. So coming to the images here, so you will now understand as to what exactly we are trying to see here. So if you can see here, your typical finding that you see here is what is known in your H&E staining. So here you tend to see that there are hyphae which are present. So these are nothing but your hyphae that you can notice here, and these are in fact nothing but aseptate hyphae that you can appreciate even in your simple H&E staining. Now when it comes to GMS staining, like I told you, the advantage is it tends to give you a better picture when it comes to fungal elements. So fungal elements, always better to get a special stain by Gomori's methenamine silver stain. Now this is the typical finding that you see. So you can see here there is aseptate hyphae that you can see, and here you tend to see that there is acute branching. So this is what is known as your KOH mount. So just a simple KOH mount can also give you an idea. So many a times surgeons insist on having a microbiologist see a suspected case very quickly, and that is because a simple idea about that this is an aseptate hyphae can also help them start amphotericin B very quickly. So this is what is considered again very typical black colored staining especially, and this is for GMS stain. So always remember, staining is very, very important, and it's a cornerstone for diagnosis in a lot of conditions, especially when you would want to start treatment empirically. So be it bacterial or be it fungal for that matter, whenever you would want to start treatment, it is always important that you have a basic gram stain which is always being done. So that also applies for fungal, where you would want to have a KOH mount done. Very simple test where you would be able to know if it's a septate or a aseptate hyphae. Now coming to radiographic features, opacification of sinuses, one important thing that you have to remember, along with patchy effacement of bony walls of the sinuses. This is something that you need to keep in mind. Now in cavernous sinus thrombosis, mucor infection can be interpreted by what is considered to be as a black turbinate sign. So all of this will be also covered by a radiologist. So this is something that is also important to remember when it comes to signs. So it's called as black turbinate sign. So thickening of your mucosa or cloudy sinuses, and you tend to see that there is proptosis, all of this going in favor of mucormycosis when it comes to the radiographic aspect of it. Now when it comes to microbiology, like I told you, simple KOH, especially for tissue which is being sent from the OT, very, very important, because you tend to see almost ribbon like broad aseptate hyphae with acute branching. Now culture is gold standard. Always remember, irrespective of what comes into play, the most important ones to remember is culture. The reason being, one, many a times for a lot of things, culture is important because this helps to identify the species, and in some cases it also helps to start your antifungal susceptibility testing. So both of these things are also important to remember, because this gives you a clear idea as to what the organism is. So Sabrot's dextrose agar, this is something that is commonly used, and you also use your potassium dextrose agar. Both of these are commonly used, and you have to remember that these are incubated at 25 to 30 degrees, and many a times these are also the ones that are helping you identify the organism. So based on the growth, it's very, very important to know. Now one thing that you have to remember here is, when it comes to these organisms, they tend to grow very quickly, so it doesn't take too long for it to grow, and these are what are considered to be as lid lifters. So what exactly do you mean by that? So lid lifters means these are the ones which grow so quickly and they grow above the surface of the media. It's almost like when you find a plate, you have the ones which grow above it and the ones which grow inside the media, right? So this looks like as if this can push the lid of the Sabrot's dextrose agar. So that is how it is described. And the appearance for Rhizopus that you have to remember, that again is very important to know. Rhizopus per se tends to have, it shows what is considered to be as a salt and pepper appearance. So two important things in culture that you have to remember: you use your Sabrot's dextrose agar, you also use what is considered to be your gold standard potassium dextrose agar. Again, potassium dextrose agar gives you a better sporulation, that's the reason why you can also use it. Incubation about 25 to 30 degrees is all it takes, and 3 to 5 days you tend to see what is considered to be as lid lifters. So this is another important feature that you need to remember. Now when it comes to culture, what are the things that you need to know? Culture, again, the most important thing that you should understand in culture is, this is in fact the one which grows very quickly. It is considered to be gold standard, and this is something that you should never miss when it comes to tissue samples. Tend to see. Now what is the appearance that you tend to see here is what is called as salt and pepper appearance. So salt and pepper appearance is nothing but what is considered to be very important when we are talking about Rhizopus. So this is something that you need to remember, which is called as salt and pepper appearance, and salt and pepper appearance is what is related to Rhizopus. Now another important feature that you have to remember is what is called as LPCB mount. So this is lactophenol cotton blue mount. So whenever you have a growth which is seen on your Sabrot's dextrose agar, you tend to take a part of it and then you see it under an LPCB mount. Now LPCB mount gives you an idea as to what exactly is the morphology that we are talking about. So a culture is always followed by LPCB mount when you are trying to speciate the organism. So important things to remember, or the important ones to remember, is nothing but mucor most importantly, and you also have Rhizopus to remember for the exam, as well as what is known as Absidia. Now understand this, we are talking about a sporangium being present. You have sporangiospores. Now these sporangiospores are the ones which are responsible for the spread of condition. You have what is called as sporangiophore. So these are considered to be sporangiophore, and when you tend to see it, the most important differentiating feature is for the fact that Rhizopus contains what are known as rhizoids. So Rhizopus has nodal rhizoids. Now the other difference that you tend to see is internodal rhizoids are seen with Epsidia. So, Epsidia shows internodal rhizoids, whereas Rhizopus shows nodal rhizoids. So, here it tends to be nodal, and the differentiating feature between all of them is for the fact that you have mucor which does not have any rhizoids. So, there are no rhizoids. So, this is something that you have to keep in mind. Culture findings, very important to know, and also the findings where you have to know that there are sporangiophore which has sporangium and sporangiospores which are responsible for the spread of condition. Now, coming to molecular methods of diagnosis. Now, this is in fact revolutionized a lot of tests which are there today. Now, molecular methods give you an advantage that this tends to have better sensitivity, it tends to give you quicker results. So, the results are much earlier when you are talking about molecular diagnosis. So, here you isolate the fungal DNA and you subject it to PCR. You also have the option of multiplex PCR. Now, what is the advantage of multiplex PCR? You have probes which are included, and you tend to have multiple conditions which can be tested. So, when you are not sure if this is mucormycosis, but you are still considering that this could be aspergillosis. So, multiplex PCR gives you the advantage that multiple suspicion of different kind of organisms can be tested with one single fungal DNA. Now, you also have the advantage that this gives you quantitative PCR. Now, quantitative PCR also helps you, especially when you are trying to follow it up post treatment, and you would want to know how much of a fungal load do you have. So, you can do a PCR, you can do sequencing, all of this is possible with molecular methods, and like I told you, this kind of makes it very easy to diagnose, makes it very sensitive. So, you tend to have better results when you are using your molecular methods for diagnosis. Now, coming to the most important one, especially because we have gotten a question previously where they have mentioned that in a case post COVID with a comorbidity of diabetes, what exactly happens in COVID? So, this is something that you need to understand. So, there are two things that you have to understand. One was a patient who had COVID, and there was always a pre-existing diabetes mellitus which was there. Now, corticosteroids, they had found that there was lot of use of corticosteroids, and that was responsible for acute hyperglycemia, and it was also responsible for new onset of diabetes. So, this was what they had noticed, and this was responsible for diabetic ketoacidosis. Now, one of the other important things that you have to remember is they have always spoken about cytokine storm. So, whenever they had spoken about cytokine storm, it was always associated with COVID. So, there was increase in interleukins, there was increase in cytokines, and you tend to see that this was responsible for increase in ferritin synthesis. And like I told you, increase in ferritin or increase in iron overload is also one of an important risk factor to remember when it comes to mucormycosis. So, this was also something which was causing it. Now, the other thing was, you have to remember that this was also causing what was known as, there is always related to hypoxia. There is something which is causing metabolic acidosis. Now, metabolic acidosis is also an important risk factor, and you also see that there were certain receptors which were present in the endothelium which was also causing an increase in the incidence. So, please keep in mind these were the different factors which were attributed to an increase in the number of cases post COVID. Most importantly, it is the abuse of corticosteroids most commonly, which has actually caused a very big problem or a pandemic of black fungus. Now, coming to treatment, very important to know, surgery is one of the mainstay treatment. There is very little you can do unless there is a surgeon involved. Now, first and foremost, when it comes to surgery, necrosis and thrombosis, this is in fact something that needs to be removed. So, the necrotic tissue has to be removed, because unless that is removed, you do not have your drugs being delivered to the site. So, antifungal drug delivery is kind of hampered if the necrotic tissue is not removed. Now, elimination of affected tissue, it is almost like debridement that needs to be done. You can pump in as much as you want when it comes to the antifungals, but unless the necrotic tissue is removed, you cannot totally eradicate the infection. Now, the mainstay of treatment, amphotericin B, very, very important, along with the lipid formulations. So, this was in fact the one which was acting on what is known as your fungal cell wall. So, this targets the ergosterol which is present in fungal cell wall, and this is in fact responsible for destabilizing the cell wall. So, this is the first drug which was approved by FDA for mucormycosis. So, they had come out with the guidelines saying amphotericin B both in the lipid formulations are in fact what should be used for treatment. But having said that, renal parameters have to be kept in mind, especially nephrotoxicity, and you have to make sure, especially the treatment becomes a little difficult when you have a patient who is already suffering from diabetic nephropathy. Now, the other important drugs which are used are called as triazoles. Now, most important one is posaconazole, very important to remember. This was a drug which was quite commonly used many times in combination with amphotericin B. In certain conditions where there was dissemination, they required a combination therapy of both amphotericin B and posaconazole. So, they mainly acted by inhibiting the synthesis of ergosterol. So, that is an important component of fungal cell wall. So, your triazoles most importantly acted on that particular region. So, these are the important things that you have to understand when it comes to mucormycosis, and very important to know because certain conditions are attributed to certain kind of underlying factors. So, always remember, in developed countries malignancy is one very, very important one to rule out when it comes to mucormycosis, but when it comes to countries like India where we tend to have a pandemic of diabetes, mucormycosis is something that you have to keep in mind when you are working in the ER, when you are in an ENT department, wherever it is. Always look for the warning signs, and diagnosis becomes very, very, very important because the earlier you start the treatment, better is the prognosis. So, it's an important topic to remember, and both from microbiological aspect as well as ENT aspect is very, very common to understand that this is very important when it comes to the Indian setup. So, this is all that you have to know about mucormycosis, and hope you benefited big time from this class. Thank you.